welcome everybody to Child and Adolescent Psychiatry Grand Rounds. We have a very special episode today. We have invited our graduating Child and Adolescent Psychiatry Fellows to share some of the scholarly inquiry work that they have been doing over the course of their two-year fellowship. So I'll be handing it off to Chris, who'll give a brief introduction in a little bit. But first, I wanted to start with a land acknowledgement. We acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people past and present, and honor with gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with Indigenous communities, but serves as one way to honor the land we are on and resist cultural erasure. We also acknowledge that this country exists and prospered as a result of the free and slave labor of Black people. We honor the legacy of the African diaspora and Black life, knowledge, and skills that have been stolen due to violence and systemic oppression. We affirm our commitment to be aware of the privilege and oppression and how they play a role in the lives of our patients, our families, and employees, as we strive to be anti-racist and improve care for those with less privilege. All right, well, June is a month of lots of celebration. June is Pride Month, and there will be lots of events all over the city. There's a link to some of those events in the slide. I don't know if people are going to get access to that link or not. Maybe we can update the invite to include that. And we also celebrate Juneteenth this month. That's going to be on Thursday, June 19th, and that is a work holiday. So a lot to celebrate this month. I'd like to turn it over to Chris, who'll give a brief introduction before our fellows begin their presentations.
Good morning, everybody. Welcome to June Grand Rounds. This is a special one for sure. And we're going to have an opportunity to hear from the rising graduates from the program who will be done with their training in 24 days. And I think this is one of the things that I really appreciate about the work that the fellows do. And it allows them, apart from the scheduled rotations that we have for them and the electives they take, to really put a personal signature on an area of interest to them. And what they've done over the years has been as varied as the fellows themselves are. They've engaged in projects on really every topic that you can imagine, and this year is no exception to that. And so they've been working on this over the course of the last couple of years, and many of them go on to use these work products that segue into presentations at annual meetings and to write papers about it that have been published. And so it's really, I think, a sign of significant accomplishment. And we learn a little bit, hopefully, about the individual or paired presenters. So that's what we're about. Each of the presenters are going to talk for about 15 minutes or so. If you have questions, do put them in the chat as we go along. Doug is going to monitor that. And we'll have hopefully time at the end to go over any questions that those of you may have. So with that, no further ado, I'm going to turn over to Jay, who's going to begin the presentation, and then he in turn will hand it off to Grace and Ellen. So Jay, I'm going to turn the podium over to you.
So the title of my presentation is Comprehensive Mental Health Care in Washington State and the Emergence of Certified Community Behavioral Health Clinics. A couple of the objectives: understand the origin of the CCBHC model and how it aligns with current behavioral health needs, identify the core clinical services of a CCBHC, gain insight into how CCBHC implementation is unfolding nationally and within Washington State, recognize the implications of the prospective payment system, PPS, and understand the impact of statewide adoption on workforce, service capacity, and patient needs. I'd like to start off with some comprehensive behavioral health models folks are probably already aware of. As we know, many traditional approaches to behavioral health fall short, especially for underserved populations. We've seen a growth of models such as coordinated specialty care, CSC, for first episode psychosis, and in Washington State. These programs are called New Journeys. There's also assertive community treatment, also known as ACT, which is a model for adults living with serious mental illness to provide comprehensive mental health care in the community. And in Washington, these are generally referred to as PACT, or Program for Assertive Community Treatment. And those are managed by the healthcare authority. So this project came about trying to understand the current landscape of comprehensive mental health care for our low-income populations and how the emergence of the CCBHC model is attempting to fill that gap with wraparound care. So a few acknowledgements. I'd like to give special thanks to Olivia Shangro and Julia O'Connor with the Washington Council for Behavioral Health. They've been instrumental in policy for community behavioral health in Washington, and were very helpful with this project of understanding the current landscape of CCBHCs in Washington State. I'd also like to thank the APA work group on the future of psychiatry. Our paper was just published in March 2025, looking at a myriad of aspects of how psychiatric practice will evolve over the coming years, including comprehensive behavioral health. So what is a CCBHC? The acronym stands for Certified Community Behavioral Health Clinics. These are outpatient community-based clinics that provide a comprehensive range of mental health and substance use services. We can kind of think of them as FQHCs for mental health care. And CCBHCs are required to serve anyone who requests care for mental health or substance use, regardless of their ability to pay, place of residence, or age. And this includes youth, families, and adults. So why the CCBHC model? They're a person, family, and community care, community-centered care design. These clinics are individually designed with a community needs assessment as the driver for staffing and the array of services. There's a focus on access and care coordination, trying to meet the needs for accessing services in a given area and extend how clinics engage with clients outside the four walls of the clinic. There's also a goal of filling gaps in services, allowing expansion of services in areas of need that have previously not been funded. So in order to qualify as a CCBHC, there are 9 core services that must be provided by the clinic. Greater than 50% of these services must be provided directly by the CCBHC, and clinics may contract with other organizations to provide some of the required services if it's not feasible for the clinic to do so. Many of these services are already provided by behavioral health clinics. However, what sets this model apart is the expectation that each clinic fully integrates all of these services. And this represents a comprehensive wraparound approach to mental health and substance use care. So I just wanted to point out one of these 9, the targeted case management services. And this is really central to the wraparound service model of CCBHCs. And they have the goal of helping individuals with a myriad of issues, such as medical, social, legal, educational, housing, and vocational support. So looking a little bit at the national growth of CCBHCs, this is a federally defined model that was established in 2015 by the U.S. Department of Health and Human Services, rooted in legislation from PAMA, which is the Protecting Access to Medicare Act of 2014. CCBHC requirements and federal funding are currently managed by SAMHSA. And the number of CCBHCs nationwide has grown exponentially, and this is largely due to grant funding from SAMHSA. The initial 66 clinics in 8 demonstration states in 2017 has now expanded to over 500 clinics operating past 46 states. So looking at some of the initial outcomes for staffing, we've seen increased recruitment and hiring of staff, and greater staff satisfaction and retention. Regarding access, there's decreased wait times for care, targeted outreach to vulnerable and underserved populations, expansion of services offered outside the 4 walls of the clinic, such as in clients' homes, school, justice-related facilities, and emergency departments. And typically for behavioral health care, nationwide, there's an average wait time for services of around 48 days. And with the CCBHC model, 71% fines are seen within a week and 87% within 10 days. Regarding community impact, we've noticed improved partnerships with schools, primary care, law enforcement, and hospitals. And for health impacts, seeing reduced hospitalizations and ED visits and improvements in physical health indicators. So in Washington, there's currently 12 CCBHC clinics funded through SIMS's expansion grant program. And this is where individual clinics apply for funding. You can think of the current clinics as pilot programs for Washington State. Their experiences provide valuable insights into best practices and potential pitfalls. And these programs have shown strong outcomes. However, there is currently no standardized state-level certification system or permitting. So there's not really any statewide infrastructure in place, or each clinic operates under the terms of its. And these grants help to support really the implementation of the model, but they don't help with reimbursement for services. And this is where the demonstration program comes in, looking at a statewide reimbursement system. In December 2024, Washington State was awarded a $1 million planning grant. In March 2026, plans to apply for the CCBHC Medicaid demonstration program. And this program requires compliance with the 9 service areas we previously mentioned and provides reimbursement through a prospective payment system of PPS. This would allow the state access to additional federal funds through Medicaid and establish a standardized certification and payment structure. And the funding would last for 4 years. So a little more about the proposed model in Washington State. And the general idea is a flexible but standardized care model. CCBHCs can partner with other organizations called a designated collaborating organization, or DCO, to provide mental health and substance use services. DCOs can extend reach, but accountability still remains with the primary clinic. DCOs may be used to supplement clinic capacity. And SAMHSA requires that at least 51% of services must be delivered by the CCBHC directly and allows any of the 9 core services to be managed by the DCOs. However, Washington DCOs not only provide crisis services, medication-assisted treatment, specialized peer support, and care for armed services in settings. So standard fee-for-service models often don't reimburse resources to address social determinants of mental health, such as housing, nutritional, and transportation needs. And a prospective payment system of PPS helps community-based organizations to focus on coordination and follow-up care for individuals with complex needs. And CCBHCs require a PPS, and there are a few different options. Washington plans to adopt the PPS 1, which is essentially a bundled daily rate. And this is calculated by dividing the total annual CCBHC cost by the annual number of daily visits. And so the PPS 1 rate is triggered when at least one of the 9 core services is delivered to an individual by either the CCBHC or one of its DCOs. There were some other options considered, including a bundled monthly. And additionally, HCA proposes implementing quality bonus payment, which is a performance-based incentives worth up to 5% of the clinic's total revenue. And these would reward providers for achieving specific health outcomes and adhering to best practices. So additional costs of the CCBHC model include hiring additional clinical staff, non-clinical staff, and increasing non-personnel expenses, such as IT, and additional enhanced services, such as targeted case management. And targeted case management is thought to be the bulk of these additional costs under the enhanced services category, as it is provided to a significant portion of clients in the CCBHC model. And with the demonstration program, there's an enhanced federal medical assistance percentage. Currently, Washington is at 50%, but this would increase reimbursement at 65% for these. And this percentage of the state's Medicaid costs that the federal government would pay. As you can see in the chart, being accepted to the demonstration program reduces state costs substantially with the increased federal support. The hope is that these initial investments could lead to long-term sustainability. And these costs reflect the 2027 fiscal year. So looking a little bit at the timeline and putting it together, the planning grant was submitted in September 2024 and awarded the $1 million grant in December. And with a plan to submit the application for the CCBHC demonstration program in March of 2026. And if selected, this is start implementation of the demonstration program in Washington in July of 2026. So just a few take-homes about this. CCBHCs can enhance access to care and improve treatment engagement for mental health and substance use disorders, as well as reduce emergency rooms. It requires clinics to serve all individuals, regardless of insurance status or ability to pay, which could significantly improve access, especially in our underserved communities. There's an emphasis on care coordination and case management. In a report to Congress published in July 2024, indicated that CCBHCs from early demonstration states have been able to maintain and even expand their services after the completion of the demonstration program. And demonstration programs allows for coordination and infrastructure investment, but will support long-term. So that is my presentation. So I will turn over to Ellen and Grace.
Hey, hi everyone. I'm Ellen, and I worked with Grace, who's one of my other co-fellows. So we were looking at the characteristics associated with youth who are overweight or have obesity with autism spectrum disorder, and we're focusing specifically on the effects of second-generation antipsychotics. So autism spectrum disorder, also called ASD, is a neurodevelopmental disorder characterized by social communication deficits, as well as restricted or repetitive patterns of behaviors and interests. And some youth with ASD present with challenging behaviors, such as irritability, aggression, self-injurious behavior. And although no medications treat the core feature of ASD, large randomized controlled trials have shown the efficacy and safety of risperidone and aripiprazole in managing these challenging behaviors. There are some other second-generation antipsychotics used, such as olanzapine and ziprasidone, which are used off-label. And while psychosocial interventions remain essential for managing these challenging behaviors, antipsychotic use has been increasing, with about 1 in 6 youth with ASD receiving such medications. And this has posed a major health concern with antipsychotic-induced weight gain, as children and adolescents can have weight gain twice the amount seen in adults. And weight gain can be stigmatizing, increasing the risk of insulin resistance, type 2 diabetes, and cardiovascular disease. We have noticed that weight gain with second-generation antipsychotics, it's called SGAs, varies between individuals, which led to our study of identifying those characteristics that could increase the risk for antipsychotic-induced weight gain in youth, so we could have more thoughtful discussions with family when we are prescribing these medications. And for the purpose of this paper, we define being overweight as body mass index, or BMI, between the 85th to 95th percentile, and obesity is defined as a BMI of at or above the 95th percentile. In our literature, we also found what the effect of co-treatment with these following medications are with weight gain. So with stimulant co-treatment with second-generation antipsychotics, stimulants are often used for ADHD, and while they can reduce appetite, studies have shown mixed results regarding its impact on antipsychotic-induced weight gain, with some reporting lack of stimulants is linked to a higher BMI, and others find no significant effect of stimulant on weight gain or metabolic outcomes. Antidepressants used with SGAs can also affect weight. Selective norepinephrine reuptake inhibitors, or SNRIs, tend to cause weight loss early in treatment, while SSRIs, or selective serotonin inhibitors, may lead to weight gain earlier or later in treatment. Those studies specific to youth with ASD are lacking regarding the weighted impact of co-treatment with SGs. We also found that health insurance is another factor associated with being overweight or obese, and possibly antipsychotic-induced weight gain. So individuals with public insurance, such as Medicaid, have higher obesity rates, potentially reflecting a link between low socioeconomic status and limited access to healthy food or safe environments for exercise. So given these vulnerabilities, insurance status may be relevant in understanding antipsychotic-induced weight gain. In summary, so while many studies have explored the risk factors for antipsychotic-induced weight gain, most have focused on youth with various psychiatric conditions, and few have specifically examined youth with ASD. So to clarify the relationship between ASG use and pattern of BMI percentiles in youth with ASD, we did a retrospective cohort study of youth taking medications diagnosed with ASD in our Seattle Children's Autism Center. So these are our study aims, comparing the demographic and clinical characteristics between youth with ASD who are prescribed SJs and those who are not. And second, comparing these characters between youth who were overweight and obese and those who are not, and exploring the effects of selected clinical factors on the overweight obesity status in youth with and without SGA treatment. So this is a table of our study sample. So as I said earlier, this is a retrospective EMR, electronic medical record review study. And the study sample is drawn from those who are in our Seattle Children's Autism Center. Our inclusion criteria were the ages between 5 to 17 years old, diagnosed with ASD, and who had at least 2 clinic visits during a 5-year study period between January 1st, 2018 to December 31st, 2022. And at least 1 or more psychotropic medications prescribed during these visits. So a total of 475 youth met the inclusion criteria. And then we selected the second clinic encounter in the study period as a target encounter and examined the EMR to retrieve height and weight data to calculate the BMI associated with the encounter. And if height and weight were not reported in that target encounter, we searched to find the first available BMI data up to 12 months post the target encounter date. And a total of 425 unique, total 425 patients had that BMI data available. Among those, 358 subjects were either consistently receiving or did not receive SJs for the entire study period. And so we broke it down between 97 who did receive an SGA or second generation antipsychotic, and then those who never did, just 261. So these are some of the clinical characteristics we studied within the sample. So there's the demographic information, whether their insurance status, BMI percentiles, also any concurrent use of stimulants, so any methylphenidate or amphetamine derivative, and antidepressants, so SSRIs or SNRIs. And for the SSRIs and SRIs, these were pulled together for the antidepressants because we only had 9 patients who received an SNRI during the target encounter. And then using ICD-10 codes, we looked at 4 major psychiatric disorders: anxiety disorders, ADHD, disruptive spectrum, behavior spectrum disorders, and depressive disorders. And as we'll show later in the outcomes, so descriptive statistics were used to describe characteristics of the study sample, which included all these. And there were like chi-squared statistics used to examine the difference in the clinical characteristics between sample groups for both those taking SJs and not, and between those with a BMI of greater than 85th percentile to greater than 85th to less than 85th. And yeah, so next will be the results section, and Grace will go over the outcomes.
Yeah, thank you so much, Ellen. I know this is a little bit busy, so I'll try to break it down for you guys. So first, these are the clinical characteristics of our study broken down by the BMI of the patient. So that's the columns. And then the rows are the different clinical variables. So you can actually see antipsychotic use down there with the other medications, but we'll kind of talk about what's surprising there. And this is using chi-squared analysis. So looking at patients who had a BMI less than 85th percentile, and that's the column on the left, and greater than 85th percentile, that's the column on the right. You can actually see that looking at kind of variables associated with statistically different percentages of kiddos in each group. We have public insurance or insurance status, so other versus public. And then we also have highlighted down low disruptive behavior disorder as the only diagnosis that was actually associated with a difference in BMI percentile. And if you look kind of, you see that stimulants, antidepressants, and second generation antipsychotics, none of those were actually associated with a difference between kiddos with a BMI less than 85th or greater than 85th percentile. So in that instance, it means that there was basically, like, for kids taking antipsychotics or not taking antipsychotics, we didn't see a statistically significant difference in the groups that had each BMI percentile. So I'll talk about this a little more later, but this is breaking the data down by BMI. And then we also broke it down by kids who were and were not on antipsychotics consistently for the duration of our study. So again, here the columns are no antipsychotic use, which is SGA minus, second generation use, and then with second generation antipsychotic use, that's the SGA plus, and again, chi-squared analysis. And this is interesting because we see some of the same things in this case, and then a couple new variables. So looking at kids who basically, like, youth who did not receive SGA versus who did receive SGA, there is a difference in a statistically significant difference, excuse me, in the disruptive behavior diagnosis, as you see the DBD. And then also you can see with the SS and SNRI use, you also see a difference there statistically, and then also in the insurance status as well, and as with the comorbid ADHD diagnosis, which is interesting. So that's, again, differences kind of by without and with SGA. So for example, with kids with public insurance, we see that, like, almost 64% in our study were on SGAs versus about 45% who were not, as opposed to kids with other or non-public insurance, about 55% did not have an SGA during our study versus 36% who did. And then similarly, excuse me, with kids with a diagnosis of disruptive behavior disorder, almost 69% were on an SGA during our study. And whereas kids without disruptive behavior diagnosis, only 30% were on an SGA during our study. Yeah, so anyway, and then also we further analyzed the data using binary logistic regression, which is, I think my understanding is basically a way to tell if there's, if you're looking at kind of like an A option and a B option, if that difference is basically significant statistically or not, so more or less likely attributable to chance. So this is looking at kids, again, who are on and off SGAs, as you see SGA minus and SGA plus, and then also looking at those categories we talked about before, kids with public insurance, kids who've been on stimulants, kids who've been on SSRIs or SNRIs, kids plus or minus ADHD, and kids with a disruptive behavior diagnosis. And what's interesting is that we're looking in this particular group at kids who are overweight and obese and who fit into those categories of taking an SGA or not. And what you notice that's interesting is that actually public insurance was associated with overweight and obesity in kids specifically who are not taking second generation antipsychotics. So it seems to be kind of unrelated to the second generation antipsychotic. However, then in stimulants, in kids, we noticed that there were basically, stimulants do seem to be protective against overweight and obesity, potentially in kids with antipsychotics, or there's a statistically significantly lower number of overweight and obese kids who were taking SGAs versus not. And then finally, again, we see with disruptive behavior disorder, interestingly, that that's actually associated with overweight and obesity in the absence of second generation antipsychotics. So I know these slides are kind of busy, so I'll also try to break it down verbally for those of you who are verbal processors like me. So first, let's talk about second generation antipsychotics and BMI use, or BMI. So as Alan talked about, right, we know about the metabolic profile of SGAs. And in our study, the mean BMI percentile was higher in youth prescribed SGAs, but was not associated. SGA prescription was not actually associated with overweight or obesity status. So although the BMI was slightly higher, obviously didn't reach that threshold. And this does contradict prior studies linking second generation antipsychotic use to weight gain in youth with autism. However, there's obviously limitations here. We couldn't directly measure antipsychotic induced weight gain. And we also are looking at patients with diverse treatment histories that we are not, like the limitations of the study, or that we're just simply not aware of or unable to kind of take into account. So our study could have included youth both on their first SDA trial as well as those who potentially had had multiple SDA trials. Since it was cross-sectional also, right, kids could have been on an SGA for variable lengths of time. And there may have also been children in the study who had previously been on an SGA, but were not currently. So even though we did not in this study see an association with SGA use and overweight obesity status in autism spectrum disorder, that obviously doesn't mean that doesn't exist. What is kind of an interesting positive finding is the correlations with public insurance and comorbid disruptive behavior disorder. So both of those were linked to overweight and /obese status in our sample. And as Ellen discussed, prior research has indicated increased rates of obesity among those with public insurance versus commercial. And there's increased use of SGAs, obviously, to address disruptive behaviors in autism. So potentially kids who do have a comorbid disruptive behavior diagnosis have significantly more disruptive behaviors than kids who don't, potentially, right? However, what's interesting is as I showed in that last data slide, the factors, so public insurance and disruptive behavior diagnosis were actually associated with overweight and obesity only in kids who were not on second generation antipsychotics in our study. So that actually suggests that second generation antipsychotics obviously are not the sole driver for weight gain in youth with ASD. And actually that, in this case, public insurance and this comorbid disruptive behavior diagnosis with autism are kind of separately associated with overweight and obese status, completely separate from the effects of second generation antipsychotics in this study, at least. And then finally, stimulant use. So previous studies have been mixed regarding the impact of stimulant co-treatment on antipsychotic-induced weight gain. And in our study, though, stimulant co-treatment did show an inverse relationship with overweight obesity. So essentially, kids with autism who were on a stimulant and on a second generation antipsychotic were less likely to be overweight or obese in our study. And that does potentially indicate a protective effect in youth with autism who have comorbid ADHD. Obviously, there's a lot of confounding factors here, right? So potentially kids who have ADHD might also be moving around more, in addition to being on a stimulant. So there's obviously many other reasons that they could have lower or have this inverse relationship with overweight and obesity, but it does indicate that potentially, when indicated, using a stimulant in addition to using a second generation may protect against some of the weight gain we see with second generations in kids with autism. So I've already kind of discussed this a little bit, but study does have some limitations. So it's a retrospective study design. So we're limited by that inherently, right? We can't assess antipsychotic-induced weight gain directly. And we also can't assess genetic markers, baseline BMI, diet, exercise, any of these many other factors that influence weight gain that are vary from individual to individual. We're just kind of inherently limited by our study in what's in the chart, so we can't assess these things directly. Also, there's variation in second generation antipsychotic exposure dose and duration in this study. So, and we are unable to control for that. So higher doses of SGAs in the literature have been associated with increased weight gain in some studies. Some studies have also found a more rapid antipsychotic-induced weight gains in the first few months of use, so potentially that the weight gain happens early. Obviously, different antipsychotics potentially have different side effect profiles or weight gain profiles, and we kind of aren't able to account for any of that in this study. We're really only looking at if they're taking one or not at the moment of the study. So those subtleties are unfortunately lost. We're also limited by a relatively small sample size, especially for some of the kind of categories of data like Ellen mentioned, the separating the effects of SNRIs, from SNRIs. We're limited by relatively few kiddos in our population who are taking those medications. A small sample size also limited our ability to examine individual different SGAs, which, as I said, potentially have different side effect profiles, as well as the use of weight attenuating medications, like, for example, metformin, just again, due kind of to inherently the sample size that we had. And also, so again, the study design is tough here. We were collecting BMI data within 12 months of the second clinic visit that the kid had the autism center. This limits our insight into long-term trends. We were also kind of limited in the BMI data, that was available in the chart. Our study did take part of the period of time we were collecting data from was during the pandemic, so potentially kids are not right. We don't necessarily have BMI data that's always super close to when we started the SGA. We weren't really able to be too particular about that. So we're not really sure both kind of short-term and long-term trends, right? We know within 12 months of them being on an SGA, but we're not sure what it would look like for these kids who are on it for years. And likewise, we don't have a great sense of the weight gain velocity that may or may not occur with SGAs. So those are some of the limitations of the study. As I said, future directions, I think this is our findings are super interesting, and I think there's lots of directions that this work could go. Certainly be interesting to see BMI trajectories with different SDAs and also potentially with other psychotropic medication classes. So to see if stimulants truly do have a protective effect in this class, or in this case, to see if SSRIs or SNRIs have more an effect if we have more a bigger pool of patients to look at. Again, longitudinal studies would be very helpful in this patient population because some of these kids are on antipsychotics longer term, but some of them we do only give for a relatively short amount of time. But it would still be interesting to see, right? Even if we're giving it only for 3 to 6 months, do they still have the weight gain early on, as the literature has shown in some cases? And then, of course, we were unable to correlate with dose or with specific medication. So correlating weight gain with doses of antipsychotics used could be interesting as well. Anyway, I obviously, and Ellen and I both want to thank Dr. Kim and Dr. Raquel for leading this project with us, and really, their invaluable insights. Dr. Kim did all the statistical analysis. So we're very grateful to them for their hard work. I believe up next is Margaret and Mike.
Hi, everyone. So Mike and I decided to create an algorithm for first episode psychosis medical workup in children and adolescents. So we'll start with some background on first episode psychosis. This will be a review for many or some of you. So first episode psychosis is defined as one's first experience of psychotic symptoms that are significant enough to be clinically recognized. And we know that psychotic symptoms are typically split into positive symptoms and negative symptoms. So positive symptoms include things like hallucinations, delusions, disorganized thoughts and or speech. And negative symptoms, we tend to think of patients that are more isolated, who have challenges with expressing emotion, who are apathetic, who might have some difficulties with tending to ADL, such as hygiene and nutrition. And also patients who experience psychosis end up having cognitive effects as well. So they have difficulties with attention and concentration, with memory, and executive functioning, such as planning and organization. This is a really good illustration of all the different domains and potential symptoms that can be involved in first episode psychosis. And I think what's really important to keep in mind with this illustration is that we often see a constellation of symptoms instead of just seeing one domain in isolation. And this is really important when we're considering the differential diagnosis of a patient presenting with psychotic symptoms. We know that psychotic disorders are relatively rare. Incident rate estimates of first episode psychosis based on a large population-based sample are approximately 86 per 100,000 person years among individuals aged 15 to 29 years. And that's when we typically see the emergence of psychotic disorders. And so this number drops slightly when we increase that age range. So it's about 45 per 100,000 person years among those aged 30 to 59 years. We also looked at stats in Washington State, and we found that the estimated annual incidence rate of first episode psychosis was about 235 per 100,000 Medicaid enrollees under the age of 65 in the fiscal year 2021. Psychotic illnesses are even rarer in youth. Generally, it is accepted that the incidence of child onset schizophrenia, which is onset prior to age 13, is 0.04% based on observations from the National Institute of Mental Health cohort. So we have to keep in mind here that the rarity of first episode psychosis in youth actually increases the diagnostic complexity and in turn how providers may approach diagnostic workup.
All right, and why early diagnosis matters. So it reduces the duration of untreated psychosis, and this has been identified as the #1 modifiable risk factor, and it correlates with a poor response to antipsychotics, more severe negative symptoms, and higher relapse rates. It also prevents neurotoxicity and brain changes, which we see with gray matter loss and dysregulated dopamine systems. And it lowers the risk of secondary damage, which is functional impairment, further cognitive dysfunction that can persist even after treatment. And further, why accurate diagnosis matters. So antipsychotic use. So these medications carry a lot of negative side effects, right? And oftentimes when a patient is improperly diagnosed, they will be starting these medications, and these medications may be kept on for an extended period of time, exposing the patient to harm. Lots of youth also report psychotic-like experiences, but few actually go on to develop a primary psychotic disorder. And psychosis cannot be better explained by a medical condition. And just to kind of expand on that, so since criteria for child onset schizophrenia and early onset schizophrenia indicate that a psychotic disorder cannot better be explained by a medical condition, all identifiable causes of agranic psychosis must be ruled out to accurately make such a diagnosis. And going on to the aims. So the goal of our scholarly project was to review the literature to get a sense of existing algorithms and consensus for medical workup of first episode psychosis, focusing on individuals under age 18. And to do this, we surveyed current providers within our institution to understand their practices for medical workup of children and adolescents presenting with new onset psychosis symptoms, and identify potential gaps in knowledge and barriers to diagnostic assessment. And following this, we organized our findings into a product that can help guide prescribers and child psychiatrists in their assessment and ideally act as a more standardized protocol for medical workup of first episode psychosis. Then going on to the literature review.
So there aren't a ton of studies out there when we were looking at algorithms and standardized protocols for medical workup of first episode psychosis. There are a lot of studies on imaging, and actually some of the strongest evidence comes from systematic reviews of adult studies in the US, Canada, and Europe against routine screening in psychosis alone without additional neurological symptoms. There was a study of young patients between the ages 12 and 30 admitted to the largest medical center in the Pacific who were presenting with psychosis and didn't have any additional neurologic findings. And the investigators of this study found that structural brain imaging, such as CT or MRI, had minimal diagnostic yield. And it's important to note that studies of imaging in children under 12 years are generally lacking. So one of the questions we had is, does setting matter? So obviously we do see a lot of kids and adolescents who present in the general hospital setting with a first episode of psychosis, and there may be differences in the extent of workup if patients are in a hospital setting, for example, where there's a lot more access to specialty consultation services, such as psychiatrists and neurologists who can help with diagnostic assessment, and also more access to fancy testing equipment like imaging machines and things like that. So interestingly, we found that regardless of whether or not a patient is in a hospital setting or a clinic, the workup and disposition recommendations have still been found to vary widely, even in the hospital setting. So, for example, on the one hand, there was this study that we found in a group of 28 patients between the ages 15 and 49 who were evaluated by a psychiatric consult liaison team in a large tertiary care setting. And these investigators found that in almost all cases, CBC, CMP, lipid panel, and TSH were ordered in the medical workup of first episode psychosis. And they also proposed some additional labs at baseline, unclear what the rationale for that was, but they recommended obtaining HIV, hemoglobin A1C, folate, anti-nuclear antibody, ceruloplasmin, some vitamins, vitamin D and B12, anti-treponemal immunoglobulin, a urine drug screen, a urinalysis, and a pregnancy test if applicable. But then on the other hand, in a larger study of 131 patients between the ages of 7 and 21 who were admitted to Children's Hospital of Philadelphia, investigators found that medical workup did not help identify an etiology of psychosis and actually might end up doing more harm than good, especially if there's incident findings. So the authors of that article suggest that without more urgent symptoms, such as fever or focal neurological signs, that workup of first episode psychosis could likely be safely limited to an outpatient clinic setting and to basic lab testing. So I think the important thing to note here is that we're seeing generally a lack of consensus in the medical community regarding workup of psychosis. And sometimes there might be more extensive testing than is clinically indicated, and this can actually do more harm than good. There's some really interesting articles on immunologic abnormalities in particular, because these present a unique challenge diagnostically, in part because we know that they can potentially present with isolated psychiatric symptoms. Also, we could have a patient who has seronegative autoimmune psychosis. So we could suspect that there's an autoimmune etiology, but when we do lab testing, there's no specific antibodies that are detected in the blood of patients with psychosis. So in such cases, if we want to present unnecessary invasive testing, for example, lumbar puncture, it's very useful to consider clinical red flags. So things like atypical psychosis, such as isolated visual hallucinations with additional neurological signs, rapid onset of symptoms, significant cognitive decline, and then systemic symptoms like fever and headache to point us towards potentially needing further workup for an autoimmune cause. We found an article where a stepwise approach was suggested so that providers are starting with the most prevalent antibodies against cell surface and intracellular antigens. So we're all familiar with NMDA receptor encephalitis, so that's a big one that the authors recommend testing for initially. And then if this testing is negative or if certain clinical features prevail, they recommend additional autoimmune antibody panels. So I think one of the biggest questions is, how do we get a broader overview, or how do we combine all the data that's out there? And there have been a few articles or investigators who have tried to do this, because unfortunately, most articles are looking at the link between psychosis and a specific medical condition instead of actually providing a broad overview. So this is a really great article by Skikic, I don't know if I'm pronouncing that right, et al., in which they sought to actually summarize and assign recommendations based on the strength and quality of studies linking psychosis with a medical condition being tested. There aren't many reviews and meta-analyses available for tests. There's only a few that are available for the most commonly ordered tests, but they did find that the highest quality evidence from systematic reviews link drugs of abuse to psychosis. And this is something that I know a lot of us, if not all of us, order a UDS when we have a patient presenting to us with psychotic symptoms for the first time. They also found that there was stronger cohort and review data that supported testing for folate and vitamin D, followed by thyroid stimulating hormone, antinuclear antibody, and ceruloplasmin. And they found compelling data for HIV testing in part because of the higher all-cause mortality and also urinary tract infections, because UTIs are very treatable and there's potential for relapse, and they can cause premature mortality. So we would want to be able to catch those when we can. And then they suggested that earlier screening might be indicated for genetic conditions when children and adolescents are presenting with first episode psychosis. So the authors of this paper proposed a tiered approach to the workup of first episode psychosis that is clinically guided. So this is the first tier that they're recommending, and these tests are recommended for all patients. So they have a number of lab tests. They have, interestingly, EEG, which is not something that we always order. And then also they recommend some baseline or monitoring tests, presumably for potential antipsychotic use. And then they have this second tier, which is more clinically guided from findings from history, review of symptoms, and physical exam. And as we can see, this is very limited snapshot of what they had. It was a very thorough algorithm, and definitely backed by ample data. But I think the limitation to their approach is that it's likely geared more towards specialists who are already familiar with the variety of diagnostic possibilities. And because of how thorough this is, it might be time consuming in terms of clinical decision making. There was also a large study on children and adolescents that came out of Columbia, and it was a group of expert pediatric physicians from multiple departments that came together to create a novel clinical pathway for the assessment of the pediatric patient presenting with first episode psychosis. So their approach involved utilization of a flow chart with recommendations for targeted history taking, specialty consultation, and routine labs or add-ons per history. And they also had some recommendations for disposition. I think it's important to note that a limitation to their approach is that it requires some knowledge of what one is testing for. There's not a ton that is included in this flowchart. And I think with flowcharts, it can be difficult to include a lot of information. And also that it includes a significant section on specialty consultation. And this might be more applicable to the general hospital setting where such specialty consultation is readily available. So, taken together, when we're looking at all the literature review that we did, there's just, an overall lack of consensus. So we really wanted to kind of fill the gap and see if we could make a more standardized protocol, and specifically in children and adolescents, because we work closely with that demographic. So our next step was to look within our institution to see common practices and to see if there was any way we could gather data to help us create a product that could be more standardized in the evaluation of first episode psychosis.
So in order to do that, we did a cross-sectional study that was performed utilizing an anonymous electronic survey to assess medical providers' comfort levels, practices, and perceived barriers regarding the medical workup of first episode psychosis. And recruitment for this was done via email invitations that you guys all got, which was distributed to the listserv within the hospital and the Department of Psychiatry. And we developed this survey by reviewing the existing literature as well as expert input from other psychiatrists and psychologists who work closely with first episode psychosis. And the survey consisted of 4 key domains. The first being demographics and training background. The next being comfort level assessment, which is self-reported comfort in ordering appropriate laboratory tests and ruling out medical mimics. Barriers to medical workup, such as time constraints, lack of guidelines, limited access to testing, and current practices, which was frequency of ordering specific lab tests and other procedures such as metabolic panels, tox screens, LPs, MRI, CT. And the survey was administered via Google Forms over 2 weeks. Participation was voluntary and consent was implied with survey completion. And there was no personally identifiable information collected. So for this first chart here, the question asked was, for patients presenting with first episode psychosis, how often would you say you pursue a medical workup? And 75% of participants reported always pursuing medical workup, while 25% reported often pursuing workup, and no participants reported never or occasionally pursuing workup. And this chart here indicates the settings that people are currently working in. And the majority of the survey participants were in the outpatient setting with 62.5%. And the remainder were in the acute care setting, so inpatient, CL, and DED. This was just data to see like what type of provider responded to the survey. So 1 person was an ARNP, 9 were attendings, and 6 were fellows. And this is the chart indicating the comfort level regarding certain workup. The majority of participants reported feeling very comfortable with ordering labs for first episode psychosis, while 5 participants reported feeling somewhat comfortable and 1 neutral, 1 very uncomfortable. Similarly, the majority of participants of 8 reported feeling very comfortable with counseling families about medical workup, while 4 participants reported feeling somewhat comfortable, 2 feeling neutral, 1 uncomfortable, and 1 very uncomfortable. And the majority of participants reported feeling somewhat comfortable with interpreting abnormal lab results, while 5 reported feeling very uncomfortable. And then the results for determining when neuroimaging is indicated were more mixed, with 5 participants reporting feeling that they were comfortable, 5 somewhat comfortable, 3 uncomfortable, 2 neutral, and 1 very uncomfortable. And the most striking results from the barriers encountered data when evaluating patients with first episode psychosis was 81.3%, so 13 participants reported lack of clear protocols as the biggest barrier, and 62.5% reported uncertainty about testing thresholds. Few participants reported family refusal of testing as a barrier, and some other responses included lack of access to imaging or lab resources in the community and discrepancy between what is indicated, as well as resource stewardship and trying to balance what families are hoping for, such as wanting neuroimaging when there was no indication to do so. And for this chart here, right, we incorporated response rates for ordering individual lab tests and other procedures into our final product. In almost all cases, the participants ordered the following tests in the workup of first episode psychosis. So like basic labs such as CBC, CMP, UA, UTOX, folate, B12, TSH, lipid panel, A1C, and HIV. And then from there, about half of the participants ordered the following tests. So vitamin D, ceruloplasmin, antitryptamine, anti-NMDA receptor, anti-nuclear antibody, and MRI. And then from there, few participants order Lyme serology with 18.8%. Other autoimmune antibodies, also 18.8%, such as anti-double-stranded DNA or thyroid antibody. And similar percentages ordered CT head, EEG, and LP was at 6.3%. Interestingly, no participants pursued genetic testing, though 1 participant did mention referring to genetics if there is higher suspicion for a genetic syndrome. And going on to our product, A handout was developed as a standardized evidence-based clinical reference to guide the medical evaluation of first episode psychosis in children and adolescents. And the design reflects the unique diagnostic considerations in this patient demographic, where chronic etiologies, including substance-induced neurodevelopmental and autoimmune disorders, demonstrate significantly higher prevalence compared to adult onset psychosis. And the content emphasize clinically relevant adolescent specific factors such as cannabis exposure and the role of neurodiversity in adolescent presentations of psychosis. Onto the design of the product. So the document's organizational structure employed hierarchical information presentation utilizing bulleted lists, tables, and symbols to facilitate rapid clinical decision-making. And this approach was intentionally prioritized high-yield diagnostic investigations while omitting like lower probability tests without appropriate clinical indications. And all the recommended investigations maintain strict alignment with the current professional guidelines, including APA, ACAP, as well as the literature review we performed, with particular attention to optimizing diagnostic efficiency through these conditional testing pathways. And the results of this survey informed the construction of the handout to ensure utility with our specific patient demographic. And like I said before, right, so some of the focus was on modifiable risks and neurodiversity, so cannabis exposure, neurodevelopmental factors such as ASD, ADHD, which may influence psychosis presentations, and autoimmune and metabolic disorders, which are more prevalent in pediatric first episode psychosis versus adult. And the goal for the handout is for it to be adaptable to a variety of resource-limited environments, and the aid serves to operationalize complex guideline recommendations into actionable point-of-care decision support, and bridging that gap between evidence-based standards and routine clinical practice and addressing the identified gap in adequate guidelines for medical testing in first episode psychosis.
As you can see, we basically follow the steps that we typically take as clinicians when we're first approaching a patient. So one of the first things that we're going to do is take a history. We're going to interview the patient. So we have some recommendations for information that should definitely be obtained when you're approaching a patient with first episode psychosis. We also include some physical exam pearls, so things that we should be looking out for when we're examining a patient. We took a more tiered approach when it came to lab testing. We have a mandatory section, so things that we feel, and this is also, as Mike mentioned, based in part on the survey that we did within our institution, but also literature review. So we have these tests that we feel like should always be ordered when a patient is presenting with psychosis for the first time. And then we have additional lab testing that follow, scroll up a little bit more, sorry, Mike. Additional lab testing that follows if then reasoning. So for example, if a patient is presenting with skin lesions or joint pains, then obtain an anti-nuclear antibody test. And then also we have a monitoring section here, which we feel is necessary, obviously, in anticipation of potential antipsychotic use. So lipid panel, hemoglobin A1C, and pregnancy test are going to be important for that. We also have a neuroimaging and EEG section. These are not required, but might be more indicated if we're suspecting a central nervous system process. And then we included red flags for organic causes, and I think this is really helpful for narrowing the differential diagnosis. So for example, when we're thinking about isolated visual hallucinations, this might indicate an organic cause like encephalitis, substances, or inborn errors of metabolism. And then scroll down some more, Mike. We actually included an exhaustive list of possible etiologies because one of the limitations that we saw, you can just continue scrolling down until the next section. One of the limitations that we saw in some of the broader overview articles and algorithms that have been attempted is that this is not included. So those that exist in the literature seem to be more geared towards specialists who have some of this background knowledge. So our goal is to be able to reach a broader audience. So also providers who might not be child psychiatrists, for example, who might be in primary care settings. Obviously, ideally, there would be specialty consultation, but sometimes that can take a long time, especially if we're in an outpatient setting. We included some quick clinical pearls if you want to scroll down. So one of the things, for example, Mike has been emphasizing in adolescents, particularly the role of neurodevelopmental disorders and overlap with psychosis. So for autism, we included features that could mimic psychosis. We talk about features of auditory hallucinations that might actually favor primary psychotic disorder. And then we make some comments on imaging and, of course, specifically autoimmune, our suspicion for autoimmune cases and what testing should be pursued in those cases. And then the bottom, just in case we do have people who aren't as comfortable with counseling families, this section on understanding first episode psychosis, I think, goes a long way with helping providers with discussing the workup and educating families on prognosis. And of course, if you want to scroll down to the very last part, recovery support with a link to new journeys. So this is something that Jay talked about. So coordinated specialty care and just providing some resources so that providers can be more familiar with what's in the community for support for these patients. So now we'll kind of go into just our discussion, and a lot of this will just be emphasizing some of the takeaway points and summarizing a lot of our findings. So obviously we know that there are specific challenges when we're evaluating children and adolescents with psychosis. There's a lot of diagnostic complexity considering some of the overlap that we see with neurodevelopmental disorders. And there's a lot of kids that do report visual hallucinations, but they don't actually go on to develop a primary psychotic disorder. We obviously have seen a lot of variability in clinical practice. We even saw that within our institution, although it was good to see the breakdown of which tests are always ordered versus ordered half the time. So it's a little bit difficult to decide what to include and what to categorize as more of an add-on test. And we'll also discuss, obviously, study limitations and some future directions that we have in mind for this project. So like I said, there's a lot of variability in first episode psychosis medical workup. There is a lack of consensus on the diagnostic approach in pediatric patient populations. And in particular, there's a lack of studies in pediatric patients. So there's not a lot in the literature that examines, especially children less than 12 years old, any kind of approach to medical workup in first episode psychosis. So this all highlights the need for more standardized evidence-based protocols. We obviously also have seen a lot of variability in clinical practice, in part from literature review, which often focuses on the link between psychosis and specific medical conditions rather than provide a broad overview of all of, like, for example, reviews and meta-analyses of all the potential tests that could be ordered when we just have isolated psychotic symptoms. And we've seen in the literature that some advocate for broad testing, and this actually came more from adult studies, and others highlight the risk of over-testing, and this actually comes from child and adolescent studies, which is interesting because I think we might be more prone to do more extensive testing in children and adolescents, maybe in part because parents are advocating for it. And we saw within our institution that there was a very diverse approach among clinicians when it came to medical workup.
Going over some of the limitations. So several limitations merit consideration. So the survey component was conducted within our single institution, which would limit generalizability. And broader implementation and validation studies across diverse practice settings will be essential to assess the tool's utility and scalability. Additionally, although the handout was informed by both literature and expert consensus, it has not yet been formally evaluated for impact on clinical outcomes, diagnostic accuracy, or cost effectiveness. And some future directions include piloting the tool in clinical workflows, gathering further clinician feedback, and tracking the process and outcome metrics such as time to diagnosis, frequency of unnecessary testing, and identification of underlying medical causes. And in conclusion, so the project addresses a critical gap in pediatric psychiatry by providing a structured, evidence-informed approach to the medical evaluation of first episode psychosis. Our findings support the need for standardized clinical guidance and highlight the value of integrating literature, expert opinion, and local practice patterns into decision support tools. Hopefully, with further refinement and validation, the tool may serve as a model for improving diagnostic precision and reducing variability in the evaluation of first episode psychosis. So the takeaway message, standardized workup for pediatric first episode psychosis is urgently needed. And our tool integrates evidence, clinician input, and practical considerations. And the next steps is focusing on validation and scalability.
And this is our class mascot, Hendrix. So I had to include her in the PowerPoint. Also, I just want to do a shout out for and give a special thanks to Dr. Christina Warner and Dr. Samantha Resnick, who helped us a lot with the product and with our final paper, and also Dr. Jack, who has given us a lot of great lectures and fellowship on this topic, and also we used a lot of his published work when we were doing literature reviews, so thank you.
I think next is Shruti.
So, hey everyone, I'm Shruti, one of the graduating fellows. I decided to create a novel self-guided resource database for waitlist intervention, and the inspiration for this project was because you get into clinic and like that first intake appointment, parents are coming in kind of angry about how long they waited for this intake appointment. I've heard countless times, right? Like, oh, I waited months or even like a year or more than a year for specialty clinics in getting to us. So they're feeling like, wow, I waited so long and I don't feel supported as I wait. So this is something that I created to try to help out our families while they're waiting a super long time to see professional help. So why give self-guided resources? As I mentioned, like there are really long wait times, as we've heard from other people. Kind of the Millman report reported that a third of people who are diagnosed with a mental health condition get treatment within a year. So 2/3 are not even getting treatment in a year. And that's just the people who have been diagnosed with a mental health condition. So certainly it takes months to even potentially years, as anecdotally and research-based kind of timelines there. The other thing is like self-guided interventions can actually help mental health symptoms. So there's a lot of systematic reviews out there looking at this, and sure, it's not effective for everyone, but it can really help kind of those mild, moderate mental health symptoms, showing that there's a lot of potential in this space. And patients are really, really interested in using self-guided resources. There was a survey that showed that 94% of patients are interested specifically in psychoeducation around therapy resources. And over 85% wanted like specific guidance on using therapy strategies at home. So they're very interested in this sort of product. Another survey actually surveyed provider attitudes as well. And a lot of providers also want to share these kinds of resources, but don't. Either they don't know how, they don't know what resources to share. There might be liability concerns. And that survey showed that like of the 70% who had a wait list in the first place, only 25% gave some kind of brief psychoeducation to those on the wait list. And it didn't specify what kind of psychoeducation that was. So pretty limited in terms of wait list intervention from mental health providers. So I looked at a lot of different resource databases online and evaluated over 23, 25 databases based on, and I evaluated them based on how readable are they? Like, can the average layperson actually understand this and actually pay attention to what's being said? Is it usable? Like, once they've read it, can they actually go and implement that strategy with kind of minimal fuss, or like kind of having that ability to just use it in their own life. Are the resources in the databases actually specific? Like, are they more kind of broad strokes, like you can use this for anything, or does it actually tell you like, oh, okay, use this strategy in this situation? And then also like how comprehensive is it, or like breadth of scope of the various categories? Does it focus solely on like one condition, or like kind of a couple diagnostic conditions, or can you use this across a variety of conditions? So some of the drawbacks that I saw when looking at these resource databases were that a lot of them are kind of pithy. They list a lot of different options without much guidance on what resources or strategies to use. So they just kind of spitball things at you, and it's up to you on, what to try first. It's kind of just like, okay, what sounds appealing, with kind of minimal guidance on why you would use one strategy over another. And then once you do pick a strategy, it's really difficult to figure out, how do I implement this? Because there isn't that much guidance in how do you actually do this strategy to help you out. Some resources were almost the opposite, which can be a good thing for those people who are really motivated and have the wherewithal to kind of parse that information. But some resources just had a lot of different categories and a lot of different strategies. So it's difficult to find that one useful strategy that you wanted. And like once you picked a strategy, there was just like a huge amount of material, like just full on modules that you had to sign up for that were free, but you kind of had to go through a lot of material. So how much is the average person on our wait list, or average parent on our wait list gonna be able to stick with this kind of module format? And I wanted to share an example. This is from our very own ACAP, or American Academy of Child and Adolescent Psychiatry. So this is an example of like how even ACAP is not the best in giving resources to families. They do a lot of there are definitely helpful resources, but just as an example of like a self-guided resource that they're giving families, this is on stress management in teens. This is found in their family resource center under the anxiety resource center. And it kind of gives you an overview of like, okay, look, teens have these kinds of stresses. What is the stress response? And like, what should we do to combat a stress response? Like, there's a relaxation response, and how can we do that? And then here's the spitballing of various strategies with limited guidance. So there's like a ton of things here, right? Like that it's like, oh, do all these things. And like, how do you pick which one to start with, or like which one you would want to prioritize over another? Like not very much guidance on that. And then also, if you're like, oh, okay, I actually do want to do one of these strategies, like say, develop assertiveness training skills. Like, what does that mean, right? They give you kind of this really short example here of like, okay, what is it and how can you use it? But that's probably not enough for your average parent and child. And there's not necessarily any further links about like, oh, go to this resource to kind of flesh out your understanding or learn about this more if you're interested. So this is kind of an example of just how even ACAP really can fall into this trap. So that's why I wanted to create my own database that was hopefully more usable for our families. So to increase usability, I focused on making things short. So really like having like psychoeducation be as short as possible, but at the same time informative. Like it needs to tell you what strategy to use when, and like how to use that strategy. Otherwise, there's no point. And also I try to use really engaging language, so keeping it like a low level, like 8th grade reading level, like no jargon, keeping the tone very informal. And then I also try to have limited options at each point. So just to give an example, I have an example workflow of like what it could look like. So I had like 9 categories of various symptoms or problems, life problems, and one of them is overcome fear or anxiety. And from that point, you can choose, okay, do I want to calm my anxiety in this moment, or do I want to fight back anxiety long term? And when you pick one of those paths, then say you want to calm anxiety in the moment, you can either pick, okay, do I just want to relax, calm down? Do I want to try radical acceptance in this moment, just like accepting things as they are? Or if I'm fighting back anxiety long term, do I want to gradually face my fears, like exposure therapy? Or do I actually want to learn skills to reduce my anxiety? So using more problem solving skills. So that's just an example of like, okay, here's like a semi-guided pathway to pick what strategy you would like to use. And so I am not the most technical savvy person. And instead of making a website, which I would like to do in the future, I made a slide deck that I turned into a PDF with various hyperlinks embedded of resources, and generally wanted to create this database to reduce user task demand at each point as much as possible. Just giving an example, like this is the whole slide deck. I have the QR code to it at the end of my slides if anyone wants it. But I'm trying to keep my psychoeducation as brief as possible. So I have like a why to use this, like, okay, so it's really tough to have a mental illness or care for someone with mental illness. Here are the situations where maybe this could be helpful. And I also have a disclaimer, like, this is not meant to replace our treatment. And I have like a how to use this. So really focusing on like, what is your top problem that you're coming in with, and just tackle that, and like using the pathways in the slide deck to figure out what resource you actually want to use. And then once you pick a resource, just pick that strategy and do it. And then just repeat the process as much as you want. And so this is where like the user can make their first decision of like, okay, what do you guys want help with? And so I have kind of, again, broad strokes categories like feel less sad, overcome fear, overcoming anger, reducing harmful habits like substance use or self-harm, feel less overwhelmed or stressed out. Taking care of myself better is really focused on physical things like improving sleep, diet, movement, like your environment. And then being better with people is really about communication, like reducing conflict, handling things at work or school better, like improving your productivity, your problem solving, and then existential crisis for figuring out what I'm meant to do with my life. So if you just click on like feel less overwhelmed, it takes you to kind of another decision point here, right? So like asking the user, hey, which track do you want to go down right now? Do you want to feel less overwhelmed, like by using relaxation? Do you want to make a plan? Because actually, like you're just freaking out about like, oh, I don't know what to do in the future. Should you actually do more problem solving skills? Or do you just want to like free flow explore, almost kind of like a little more psychodynamic-y? Like, should you just kind of use like processing reflecting techniques? Or do you want to kind of go back to basics, like reorient to like what matters to you in your life, like an act-based therapy? Do you want to reconnect with your values to kind of help you regain direction in your future? So just thinking about, let's say this person wants to like feel less overwhelmed right now. So looking at kind of like the relaxation strategies, I have a little psychoeducation about like, why would you use this strategy? And then also connection to outside resources. So this is like stuff that I've linked to that I thought like, okay, these resources are useful. They're short enough, but they also explain like, what are you actually supposed to do with this strategy? And I've used like a lot of different sources in general, but I'll just show you a couple of them. And so I linked to like the Seattle Children's PAL line resources, for example, like using progressive muscle relaxation or paced breathing. Like you can just go directly to that site, and then it'll give you some, psychoeducation about like, how do I do this and why should I do this? And like you can pick like, okay, maybe like I want a different form of relaxation, like I want to distract myself or I want to use mindfulness. And if you go to distract, like, okay, what kind of resources should you use to distract myself, like maybe I want ideas for like a pleasant activity. And again, it goes to an outside resource that shows you, oh, okay, like here's all this information about like, why would I use this? Like, and how would I use this? So that I really like this Now Matters Now for a lot of DBT like skill resources. I've used that as an outside resource a lot. And then unfortunately, I don't have like a direct back button, but I have a button that'll take you back to the homepage whenever you want to go back. So kind of back to the slides. Okay. So I was lucky enough to work with the Family Advisor Board with Seattle Children's, and I worked with 4 different families or parents. They saw kind of an older prototype of the one I showed you guys. Some of the feedback I got was like they would like local resources and especially like emergency crisis resources for like what to do in an emergency. Which is one of the limitations because this project is also for APA SAMHSA. I wanted to keep it like very general, so not even just child focused, but also potentially adult focused, which is why this is really heavily geared towards parents, but older teens could use it too. Another kind of feedback point that I definitely want to use is that maybe a little bit more psychoeducation in the beginning about like what could mental health professional help look like? What does mental illness in the first place look like? And that's something that I'd like to kind of expand on a little bit. Definitely a website would be easier to use and distribute. So that is something that I'm hoping that someone else could pick up and run with. And this stuff is harder to use if in a crisis. Like I've tried to make it as seamless as possible to pick something. At the same time, you still need some wherewithal to like read the descriptions and use the strategy. So a little bit of motivation, maybe a little bit of support is still needed. And then overall, these 4 families did feel like actually even in this format, it is helpful and they would use it for their kids and for themselves. And they overwhelmingly were like, you should give this to people on the wait list. This would be helpful. So that was really great feedback that sure, there's a lot of room for improvement. And at the same time, there is a use for this. So some of the limitations I already talked about, but kind of expanding on that. There are innumerable online resources for mental health, which is also part of the reason why I wanted to make a specific vetted resource database, because you're just like swimming in a lot of different resources. If you try to look at this up online, and you're not sure like what's actually vetted, what's actually useful. So I looked at only like the most popular, well-reputed resources for myself. This guide isn't meant to be super comprehensive. Like I try to make it as broad as possible, but I'm not including everything on it, right? Like I'm not including like psychoeducation about severe mental illness. And I decided to balance kind of like some of that because like having too much on there would decrease usability and like having to parse out what do I actually need for myself. And again, those lacking support or people who are severely ill are not necessarily going to have the wherewithal to be able to use these resources, even though I've tried to reduce like how much they need to think through about like how to pick a resource and use it. The other thing is I haven't really compared this yet to the use to other similar waitlist interventions, but also it's like really difficult to find out what are the other similar waitlist interventions out there. Like everyone's kind of doing their own thing. And there's very like lack of transparency around these practices. So future steps, definitely want to make a website. Hit me up if you have the skills and would like to do that. Then I would, and especially being mobile friendly so that people can just use it on their phone on the go, instead of having to use it on their laptop. The other thing is I would want to distribute this to clinics to give as a waitlist intervention, actually have this be used and solicit feedback on like from users, like, did you actually think this was helpful? Was it usable? Was it effective for you? And then the other thing too is like creating some sort of workflow for the future to allow for an update of this guide. as we know, like some websites can get taken down, information can change. You want to make sure you're still giving patients vetted, good resources that you can feel confident giving someone. So I'd love for someone to pick up this project and keep it updated. So a lot of acknowledgements. First off, as I mentioned, this project is also for APA SAMHSA, and really grateful to the Minority Fellowship Program for accepting me and giving me resources to complete this project. Really, really grateful for my mentors, including Alyssa Hemke, Rashi Agarwal, Laura Kastner. They've given me invaluable feedback about this and like giving me a lot of different directions on how to improve this, where to go with it. So I really appreciate their help. Huge shout out to the Family Advisor Program at Seattle Children's. Like those parents were really, really helpful in giving a lay person's opinion and giving their time to, and support for shaping this product. And shout out to our program directors, Dr. Shao and Dr. Barley, for encouraging me to accept the SAMHSA Minority Fellowship Program in the first place, and helping us have time for our scholarly and careerly projects and encouraging this project overall. And here are my sources, and as said, like here's the QR code to my product if you just want to run with it.
Today we heard about quality improvement strategies that we can, very practical implications for our own system, community mental health care, and public health initiatives, serious mental illness, and psychopharmacological practice. Big ups for all your hard work. So Chris has a couple of questions for Dr. Davidson. The first question is the program, and again, Dr. Davidson's presentation was on certified community behavioral health clinics and that model. Is the program you describe affected by the federal budget cuts? I have that same question, and I would like to just add on, or the Washington state budget crisis.
I think the big answer is we don't know what is going to happen. There is not currently cuts to the demonstration program. After seeing the question, I did some research online. It looks like there was some sort of file that was leaked from the president of like intention to cut programming for these demonstration programs, so that it is very much a concern. But currently, how they're merging SAMHSA into this new organization, it's not yet. Regarding the deficit in Washington, I think that's part of why the proposal that they're looking at, of one of the charts that I showed, somewhere between 5 and 15 clinics, was taken into consideration the financial situation of Washington State. But this is truly so yeah, very concerning, and but as of right now, it is.
And Dr. Varley has a second question for you, Dr. Davidson. Can you talk about how this model interfaces with the existing community mental health system?
Yeah, so I think part of this project is trying to understand myself, kind of what the current community mental health system looks like in Washington State. And kind of two things that I found from that research. One, that providers, clinics, and administrators are in general on board with what these behavioral health clinics could look like. And I think the biggest concern that I found come up again and again is just how much of a hodgepodge of a kind of organization there is, kind of from Medicaid and disseminating down to the rest of the state. There's kind of these different services that exist, and are kind of managed through a managed care organization, but again, it doesn't seem to be as straight to code. And the idea with the CCBHCs is that everything for an individual is kind of under one group. So you, as a patient or client, you're connected to a certain clinic, and they have all of those services either at that specific clinic or connected to one of those services, as opposed to kind of being a pretty difficult full criteria services that first meet with.
All right, thank you, Jay. My turn. Let's see. This is a question for Dr. Wolliver and Dr. Dang. I have questions about the early onset, the under 12 population, just because we have one of these in our in Dr. Quo's clinic and the continuity clinic. And curious if I know there's not data to sort of guide us here, but in your own view, how might an early presentation change your calculus around screenings and around how you counsel parents?
Yeah, great questions. Well, yeah, I think one of the things to keep in mind is we know how rare child onset schizophrenia is. So that stat of being 0.04% proves how rare it is. But I think you highlight a really important point is that there's not a lot of data out there examining usefulness in tests in younger children. There was that one study that came out of CHOP that started at age 7. And they did, if you recall, they found that there wasn't a lot of diagnostic yield with medical workup in general. And so they recommended just limiting to outpatient setting and doing more basic lab testing. So I don't know that I would necessarily lower the threshold. We do have, I think in our algorithm, still a lot of clinically guided recommendations. So in kids, we might see more genetic syndromes. So we might see 22q11, or DeGeorge syndrome, we might see Fragile X syndrome. So if we're seeing certain dysmorphic features, and we included this in our handout, then we might want to do genetic testing earlier. So I still think it's useful to do a more tiered clinically guided approach to avoid over testing. I think it's challenging because I know, especially when kids are presenting at a younger age, that families tend to advocate for more testing to make sure. I think for them it's reassuring, and I also think a lot of the times they're looking for an organic cause, because the thought of it being a primary psychotic disorder like schizophrenia is very, very scary. But I do think when it comes to counseling, it's important to keep that in mind about how scary that can be for families. If it truly is a primary psychotic disorder, I think like really emphasizing early intervention, because we know that early intervention leads to better outcomes. I know Dr. Sam has a lot of stats on prognosis and kind of the trajectory of these psychotic disorders and what it can look like. So education is really important. But I think family work is super, super vital in cases of early onset as well. And I think that's a really good opportunity to improve prognosis. And I know there's programs in the community that involve that do a lot of family work. Like I know Harborview has one. I'm sure New Journeys does. I'm not as familiar with New Journeys because I haven't worked in that setting. But yeah, I think early intervention, making sure that families and kids have the supports that they need in place, can go a really long way with early onset.
Great, thank you. All right, our next question is for Dr. Potival. Let's see. This comes from Dr. Groves. First, also a lot of nice comments about the quality of the work and the practical implications that a lot of your presentations have. So Dr. Groves asks, Shruti, do you think it could be feasible to incorporate some self-directed MI motivational interviewing strategies or reflections that might help people decide how to prioritize different skills? How might you do that?
Yeah, no, I really appreciate that comment, because that is something where it's like, ooh, how can I further reduce like the amount of thinking the user has to do in picking what's actually helpful for them. And I think like that could be an interesting thing to do, like the MI strategies, and explore that up top of like, okay, what are some things to think about before you go down one of these pathways? Like, how do you pick maybe your top problem, or what are you looking for? I think like maybe traditional MI is a little too jargony to like directly import. But I think making it like more informal, more accessible in some way is definitely something I'd want to explore.
Great. Let's see. For Doctors Kim and LaPierre, this is another one from me. I was really interested by the correlation between higher BMI and state insurance. That's also a really thorny issue to handle. Or I should say, a sensitive issue to handle. Just wondering if you guys had any ideas about how to counsel families in that setting, or even if that's necessary.
I guess I'll go and then Grace. Well, I think first is the awareness. So we have a family, look at the insurance, Apple Health or some kind of Medicaid, and realize that if we do get to a point of prescribing a second generation antipsychotic, like just being I think just awareness is the most important thing. And now how to weave this into families? I think the thing with like Medicaid, which you all can appreciate, and people who have a lower socioeconomic status is that, I think people know, like, eat healthy, exercise, like we know the behaviors. There are just a lot of systemic factors that work against families to do those behaviors. And also too, as people like who we're in training, learning about behavioral therapies, or there are definitely some experts here in that, is that it takes a lot of work too to like to change behaviors. So I would, if I'm starting to think, like, I think I'm gonna use the antipsychotic maybe down the line for this family, understanding more about what's like the context of the family, like would it even be possible to fit in all these healthy behaviors that we're aware of? Like, are there some, like, I mean, for example, like if it's a father who's like working a minimum wage job and comes home at like 9 p.m., like probably like that might be helpful to know if I'm gonna, before like suggesting like they should like play outside together. So yeah, I would just like think just the first awareness, and second, getting a better understanding of the family structure, what the day-to-day looks like in the family. And Gracie can jump in.
No, I definitely agree with Ellen. I think it's a important topic that kind of transcends any clinical setting and kind of really any medication side effect profile. And I think there's been a lot of good research on it, but I think, yeah, mostly sort of holding the dialectic of advocating for those systemic and community changes to help make safe outdoor spaces and nutritious food more affordable and accessible for everybody. And then also kind of, yeah, helping work with the family to figure out if there are barriers that can kind of feasibly be overcome to help them kind of make sure they're, yeah, to help them see what they can access. And sometimes the answer is like, there are barriers that can be overcome, and sometimes it's maybe a little more complex than that.
Yeah, thank you. I think that's it for the questions in the chat. So opening up to the Zoom room in case anybody has any questions that have come to mind. Oh, it looks like we have another comment from Christina here, calling out that behavioral interventions do not always mitigate the weight gain associated with SGAs. Very, very active patient who gained 20 pounds on olanzapine in a month. Scary, impressive. Yeah. Serious issue. If anybody has any questions, they can either raise their hand or unmute.
I just had a comment for Shruti's presentation. I didn't get to catch all of these, but this looks like a great compendium of skills-based approaches that people can do independently. And I'm also participating a little bit with kind of disaster preparedness. And it occurs to me, if that happens, there are going to be a lot longer wait lists for actual care. And so implementing some of these strategies on the fly can be super useful in that domain too.
Yeah, I appreciate that. I was also looking at like psychological first aid too, like, because I think that's especially meant to be a part of like disaster recovery responses. But again, that's like, oh, you have to do a whole module and sign up. Like, are people really going to do that? So I'd love to, yeah, partner with people or have people like take this and run with it if anyone's interested.
Looks like we have a comment from Dr. Weiss. This is an important one. So higher BMI does not always correlate with quote unquote unhealthiness. And many children with ASD are there's the flip side too, are actually underweight due to picky eating, ORFID, stuff like that. So spectral awareness around BMI there.
Definitely. I think another kind of imperfect aspect of our research is exactly like both kind of unpacking the inherent fat phobia of medicine, and then also thinking about like, yeah, what are the nutritional and health issues kids with autism do face? Because sometimes, right, we actually would love for them to gain weight, or even if they are, not low weight, they're not really, they still have nutritional deficiencies because of their food preferences, for sure.
I just want to make a comment at the close here. Again, just congratulating everybody on their presentations, and really a rich series of discussions, and they're instructive. They tell us about new information that Jay shared that I wasn't aware of when he first told me he wanted to do this project, and provides a lot of framework about that. And the other guys, I think all of them have the potential to be integrated into our own practice in terms of what Shruthi's offering for wait lists, and what might be done in the Autism Center with Sue and others about monitoring kids with whatever your framework about weight management is or isn't, and really thinking about implementing an algorithm that Mike and Margaret put together. We need all these things. And in the past, some things like that have been done as a direct result of fellows' work projects. And I think this is another example of just excellent and yet divergent projects that the fellows have gotten themselves involved with. And to me, it's just one of the best things that they do or we do with them. Just I want to thank them for their efforts.
I second that, and I think we'll wrap it up. There will be no grand rounds in July, but in August, we'll be hearing from our psychology trainees with some of the work that they've, scholarly work that they've been doing. So we'll send out a reminder about that when the time comes, but we'll see you then.